Again, I'm Chuck Dennis with Urinary Tract Infections, or Urinary Technologies Corp. We're developing new diagnostic and antibiotic tests for urinary tract infections. UTIs are painful, they are expensive, and the initial treatment does not work over half the time. The diagnostic test is a multi-billion-dollar test, surprisingly, but not when you understand that this is the second most common infectious disease in the world. The test for UTIs hasn't changed in over 70 years, and that's the problem. The test basically is smearing urine on a petri dish, letting it grow for a while and see what grows. Then take samples of what grew, put it on more petri dishes with antibiotics, and figure out which antibiotics work. The problem is that process takes 2 to 3 days. As a result, clinicians typically do not run the tests. They just prescribe a new antibiotic and send the patient home. The problem that practice has resulted in rampant antibiotic resistance in this space, and the antibiotic does not work half the time. Our solution to this is a better, faster test. What we know in the past is that just 9 species of bacteria actually cause about 99% of UTIs. We can test for those with probes instead of needing to use a petri dish to look for anything and everything. That's much, much faster. In addition, we can run antibiotic tests in small wells, which lets us do them just as fast. So the result is that we get an answer back to the doctor within less than 2 hours. That lets the doctor prescribe the right antibiotic the first time. Development wise, we have a strong proof of concept with high sensitivity and specificity. We are in the process of developing our core components, and we anticipate US launch about 2 years after funding. We have assembled a very strong technical, regulatory, and business team, and we are looking for $1.25 billion. I'd be happy to take your questions at this time.
You stayed within 2 minutes. Judges, any questions?
Chuck, how do you describe the antibiotic resistance better? I can appreciate the diagnostics, but I'm confused on the antibiotic resistant component.
So most antibiotics, traditionally we grow them on petri dishes because that was the only way humans could see them. They actually act within a relatively short period of time when they have a small sample. And so we can put them in a well, put the sample in the well in a very small well, 10 micron well, with antibiotics, and then test for living organisms and figure out which wells have no living organisms in them. Those antibiotics obviously worked.
Some pretty nice claims, strong claims around improvement in accuracy and detection. Is there any way that you're able to prove that out? And is there a way then, based on that differential, that you could drive that to standard of care? And what would that process look like?
Yes, we actually have already done a proof of concept. We have tested, just to test the general concept, we used off-the-shelf things that we could buy to test and then modified them and then ran our tests, and we got results that were quite dramatic. In terms of how do you use that to penetrate the market, we would actually expect to go first into hospitals where catheter associated urinary tract infections, CAUTIs, are a significant concern because it affects Medicare reimbursement. It also costs the hospitals about $13,000 per patient unreimbursed because it shouldn't happen. And so we think we can use that data to go into the hospitals very quickly, and then over time work our way out to the individual medical practices where obviously you have a lot more people you have to reach. So it would take longer.